Protrusive occlusion relations. Previously, we dealt about lateral occlusion relations. Let's talk about the protrusive occlusion relations. We have two types of protrusive relations. One is lateral protrusive, one is the protrusive relations. Let's talk about the protrusive occlusion relations. The anterior teeth in their protrusive occlusion relations negotiate the process of biting or shearing wood material. Although the mandible may be lowered considerably in producing a wide opening of the mouth, the occlusion of the anterior teeth is not concerned with any arrangement very far removed from the centric relation. When the jaw is opened and moved directly forward, when the jaw is opened and moved directly forward to the normal protrusive relation, the mandibular arch bears a forward or anterior relation of only 1 or 2 mm in most cases to its centric relation with the maxillary arch. The protrusive occlusal relation places the labio-incisal areas of the incisor ridges of the mandibular incisors in contact with the linguo-incisal areas of the incisor portions of the maxillary incisors. The mesiolabial portions of the mesial cusp ridge of the mandibular canine should be in contact with the maxillary lateral incisors distolinguo-incisally. From the protrusive occlusal relation, the teeth glide over each other in a retrusive movement of the mandible, a movement that terminates in centric occlusion. During this final shearing action, the incisor ridges of the lower incisors are in continuous contact with the linguo-incisal third portions of the maxillary incisors. From the position of protrusive occlusal relation to the return to centric occlusal relation, the maxillary canines may assist by having their distal cusp ridges in contact with the mesial cusp of the mandibular first premolar. The mandibular first premolar they cooperate with the incisors most of the time in one way or another. A slight movement to the right or left during protrusion will bring the canines together in a biting manner. In addition, at the end of the incisive cycle, the contact of the canines with each other in centric occlusion lends final effectiveness to the process. Let's talk about the neurobehavioral aspects of the occlusion. Up to this point, the emphasis has been on the structural anatomical alignment of the teeth. Up to this point, the emphasis has been on the structural anatomical alignment of the teeth. Chapter 15 mentions briefly some of the aspects of the mandibular positions and movements. Chapter 15 mentions briefly some of the aspects of mandibular positions and movements and muscle function. In addition, although it would be impossible to do justice to the topic of neuroscience of occlusion in a brief review, although it would be impossible to do justice to the topic of neuroscience of occlusion. In a brief review, it is imperative to call attention to the meaning of occlusion in its broadest sense. Recent ideas concerning the diagnosis and treatment of disturbances such as chronic orofacial pain, temporomandibular disorders, craniomandibular disorders, and bruxism, and the diagnosis and treatment of malocclusion involving orthognathic surgery require a greater knowledge of the neurobehavioral aspects of oral motor behavior than ever before in the practice of dentistry. The neurobehavioral aspects of occlusion relate to function and parafunction of the stomatognathing system. Function includes a variety of actions or human behavior such as chewing, sucking, swallowing, speech, and respiration. Parafunction refers to actions such as bruxism, for example, clenching and grinding of the teeth. All these functions, that is functions and parafunctions, all these functions require highly developed sensory motor mechanisms. The coordination of occlusal contacts, jaw motion, and tongue movement during mastication. The coordination of occlusal contacts, jaw motion, and tongue movement during mastication requires an intricate control system involving a number of guiding influences from the teeth and their supporting structures, TMJs, masticatory muscles, and a higher centers in the central nervous system. Frequent contact of the teeth during mastication without biting the tongue, closure of the jaw to facilitate swallowing, that is occurring about 600 times a day. Remarkable tactile sensitivity, remarkable tactile sensitivity in which threshold values for detecting foreign bodies between the teeth may be as little as 8 micrometers, and the presence of protective reflexes suggests and the presence of protective reflex, for example gag reflex and cough, suggest the need for intricate mechanisms of control of jaw position and occlusal forces. The presence of several classes of teeth, powerful musculature, and a most delicate positional control system indicates that it is important to understand the strategy underlying such sensitive control mechanisms. Although the ease with which these mechanisms may be disturbed at a periphery, that is, teeth, joints, periodontium, peripheral neural system, and centrally, that is, brainstem and higher centers, is not well understood. The adaptive capacity of the stomatognathing system appears to be considerable. The adaptive capacity of the stomatognathing system appears to be considerable on an individual clinical basis. However, the responses of a patient to occlusal therapy may be reflected in oral behavior outside the range of normal, in as much as function and parafunction share similar anatomical, physiological, and psychological substrates. It is necessary to review briefly the neurobehavioral correlates of the activities of the stomatognathing system. Now let's talk about the Occlusal stability. The stability of the occlusion and the maintenance of the teeth position dependent on all the forces that act on the teeth. Occlusal forces, eruptive forces, lip and cheek pressure, periodontal support, and tongue pressure are all involved in maintaining the position of the teeth. As long as all these forces are balanced, the teeth and the occlusion will remain stable. Should one or more of the influences change in should one or more of the influences change in magnitude, duration, or frequency, stability is lost and the tooth and the teeth will shift, disrupting disrupting a previously stable occlusion. The loss of the teeth, tooth structure, or occlusal supporting cusps, or a decrease in their support from periodontal disease or trauma is a factor in maintaining occlusal stability. The loss of the teeth, tooth structure, or occlusal supporting cusps, or a decrease in their support from periodontal disease or trauma is a factor in maintaining occlusal stability. Occlusal stability refers to the tendency of the teeth, jaws, joints, and muscles to remain in an optimal functional state. The mechanisms involved include mesial migration of the teeth, eruption of the teeth to compensate for occlusal wear, and or intrusion by occlusal forces, remodeling of bone, protective reflexes, and a number of others even less understood than those just listed. Although the strategy for stability related to the functional level required for survival appears obvious, orchestration of such diverse mechanisms can be couched only in terms such as homeostasis. The influence on occlusal stability of such factors as disease, aging, and dysfunction has yet to be clarified. From a clinical standpoint, several concepts of occlusal stability are used as goals for occlusal therapy, including maintenance of a stable jaw relation in centric occlusion and centric relation, direction of occlusal forces along the long axis of a tooth, maintenance of centric stops supporting cusps and the contact vertical dimension, replacement of lost tooth, and control of tooth mobility. Discussion of these aspects of occlusal stability is more appropriately found in books on occlusion. Discussion of these aspects of occlusal stability is more appropriately found in books on occlusion. Right? Mesial migration is a term used to describe the migration of the teeth in a mesial direction. The cause of this phenomenon has not been fully clarified, although a number of ideas have been advanced. There seems to be little doubt about the mesial drift that occurs. There seems to be little doubt that mesial drift does occur, but no general agreement is evident on how much movement occurs, which teeth move, and how the movement is achieved. Suggested causes include traction of the transeptal fiber system, forces of mastication, and tongue pressure are all the causes of this movement. The strategy behind the mesial migration appears to be related to closure of proximal tooth contacts, although occlusal forces may be considered as a passive mechanism and the traction of transseptal fibers as an active one. It is difficult to determine in what way occlusal stability is influenced. The contact relations of the teeth may promote occlusal stability, but if incorrect relations are present, opening of proximal contacts can occur. You can see in the figure 16.50. This is the figure 16.50. Picture A showing the opening of the contact between mandibular molars due to a protrusive interference on the second molar. You can see the mirror view of the left side. In picture B, you can see the outline of the excessive restored mesiobuccal cuspage, which involved protrusive bruxing by the patient. Now, a tendency exists to assume that a particular arrangement of teeth is unstable. You can see in the figure 16.51. Then figure 16.51 showing the occlusal instability cannot be determined simply on the basis of occlusal contact relations and spacing of the teeth. A changing occlusion that restabilizes suggests adaptation. A changing occlusion that restabilizes suggests adaptation. However, such an occlusal relationship may have become stabilized, at least at a particular point in time. Whether an occlusion is fully stable can be determined only by periodic evaluation of that occlusion. Whether an occlusion is fully stable can be determined only by periodic evaluation of that occlusion. Many factors such as caries, periodontal disease, occlusal trauma, bruxism may upset the delicate balance of any already marginally stable occlusion. An ideal occlusion may be defined as one that has no structural, functional, or neurobehavioral characteristics that tend to interfere with occlusal stability. A response to bruxism may be loss of tooth structure, increased tooth mobility, root resorption, you can see in the figure 16.52, or decreased tooth mobility and increased density and thickness of the supporting tissues. This is the figure 16.2. Root resorption associated with high restoration and a clenching habit, right? In the top and prior to placement of restoration in the bottom left, right? Soreness of the mouth. See in the bottom left, you can see the soreness of the there is a soreness of the tooth began soon after the restoration and then rapidly some root resorption High restoration was removed by selective grinding. In the bottom right, you can see several months later, no evidence of soreness or additional root resorption, right?